Okay, we'll go ahead and get started. Can everyone hear me? Can you hear me, Lisa? Okay, so if you guys were here yesterday, you know about the questions and the answers. You can put in the chat, or you can go to the Q&A and ask the questions. And Lisa, I'll keep an eye out on that so that if there are questions at the end, I can give them to you. You guys will have, the nurses will have 1 CEU for this course or this session. And without further ado, I'd like to introduce Dr. Lisa Costello. She is an assistant professor in the Department of Internal Medicine and Pediatrics at WVU in Morgantown, and her clinical duties include being the director of the Mountain State Cystic Fibrosis Adult Program and a pediatric hospitalist at WVU Children's Hospital. And in addition to serving on the WVU School of Medicine on admissions, she also leads a healthcare literacy and patient advocacy curriculum thread for the MD program. And I'm going to leave it at that. And I'm going to say that I had the privilege of working with Lisa up on pediatrics, and I can tell you that she takes very good care of her little ones, and just had a great time working with her. And I think Lisa, if you want to add anything, you go right ahead.
No, thank you so much for the kind introduction. And just for the purposes of this talk, that might be more helpful. Yeah. Carol's one of my favorite nurses, getting to work with her here at WVU Medicine Children's. I'm actually here working in the hospital now, so there might be some people walking in and out behind me. I'm on our newborn nursery. And then for the purpose of this COVID talk, I actually am no longer the director of the cystic fibrosis program. I now do all pediatrics, but since last March, I've been working with the state, the Department of Health and Human Resources, and then more recently, the Joint Interagency Task Force for COVID-19 Vaccines, assisting with the pandemic response. So I really appreciate the opportunity to speak here today. Want to say thank you for all that you do. Obviously, as a pediatrician, children are very near and dear to my heart, and I think education and those who interact with them in the school setting, from school nurses to teachers to administrators to environmental service individuals to bus drivers to everyone in between and everyone that I would miss, play such an important role in educating our youth, and really all the way through higher ed as well. So we're going to have 2 sessions on COVID. So the first part, I'm going to kind of give us a little bit of a history lesson of COVID and just talk about COVID itself, the disease, and kind of what we've learned and where we're going. And then we will spend a good amount of our time on vaccination. And then our second part, if you all choose to come back for COVID round 2, we're going to talk specifically about intentions, perceptions, and beliefs of individuals in them wanting to be vaccinated, including some parent data that we have that's more recent, and what we have found here specifically in West Virginia, and what we can do to hopefully help improve vaccine intention in West Virginia. So I will share my screen here, make sure you all can see that. Are you all able to see my screen? All right, so let me see if I can make it be in presenter mode. If you can't see the screen, someone come off mute because I can't see any of you or the chat. Are you
You're good, Lisa?
All right. And so I just want to give credit to my colleague, Dr. Krista Capehart, who works in the WVU School of Pharmacy as well as the Board of Pharmacy, and serves along with me on the Joint Interagency Task Force for COVID-19 Vaccines. And we kind of co-created these slides for some of the material. But I have no financial disclosures. Here's just some of the learning objectives for this first talk. We'll kind of just talk about COVID-19. I know we've talked about it a great deal. We certainly are going to talk about vaccines. And then I have a few brief slides on the recent CDC guidance that was just released within the past week on return to school. So really going into just a throwback of history, I mean, SARS-CoV-2 or COVID-19 as the disease is still really new to us. And so, first identified in late 2019. But this is just kind of a overview of where we generally see respiratory viruses in the US. For those of us who work with children, we know this because many of us have ourselves experienced this. But we can see with seasonal influenza how many illnesses and deaths there are per year. So, up to 58 million illnesses a year with up to 100,000 deaths per year. RSV or something certainly that we see a great deal of. Usually more the fall, winter, and spring. I will say, very interestingly, I was just on a pediatric inpatient unit in May and June. We saw more RSV in those 2 months than we had seen the prior really 12 months. I think it probably has to do with individuals no longer wearing their masks as we saw some of those mandates get rolled back. And so we've seen more RSV into the summer months, which is definitely atypical. But we see, 57,000 children less than 5 years of age get hospitalized a year, along with older adults. And then we do see adult deaths and children deaths as well. And so here you can see some other viruses: paraflu, croup, adenovirus, and then coronavirus is not SARS-CoV-2. So we have many different coronaviruses that we'll talk more about. And as well as human metapneumo. So many of us are very familiar with these. And I do want to give attribution to Dr. Lauren Spadafora, who's a former DHHR respiratory epidemiologist who graciously shared these slides from the Bureau for Public Health in DHHR. So the whole preface of this is that, we have many respiratory viruses that impact us, every year. And then we had kind of emerging viral respiratory illnesses. So this isn't necessarily new. In 2003, we had SARS-CoV. And so this originated in China. And so we did see cases and deaths, but certainly nothing than what we've dealt with for the past, year and a half. In 2009, many of us, if you were working in the school system or in healthcare, then you very much remember H1N1, so the influenza A, because it had a more predominance to really impact younger individuals and cause severe disease. And so there was a large vaccination effort in schools to try to help, curb the spread of that disease. And then in 2012, we saw MERS, where we had 2.5 thousand cases, 858 deaths, all linked to an Arabian Peninsula, had direct contact with camels. And then in 2014, many of us saw more so in the Midwest, although we did have a few cases in West Virginia with acute flaccid myelitis, where this was caused by an enterovirus, had fever, respiratory illness, and then you had this sudden limb weakness. The cases there, the majority were in children. So emerging viral illnesses are something that we always monitor and that we have seen in the past. But certainly the one that we all have become familiar with is SARS-CoV-2, or the virus that leads to the disease COVID-19 that has led to this worldwide pandemic with millions of cases, hundreds of thousands, millions of deaths worldwide. And so coronavirus is a large family. It's single-stranded RNA viruses that affects both animals and humans. So there's far more coronaviruses out there. Many of them impact animals. We have seen 4 endemic in humans that cause the common cold. And I can tell you, even when I was just on in June here recently, we had patients admitted for a coronavirus, not SARS-CoV-2. And so they do tend to follow a seasonal pattern. And we know that reinfections occur. And that has been the ongoing discussion with SARS-CoV-2. If you got natural infection, could you get reinfected? Same thing now that we have vaccination. And then certainly what's circulating in the news are variants or new strains of the virus. So we know that viruses change and mutate over time. We follow that. And certainly the Delta variant, which has become the most prevalent variant that we're seeing here in the United States now, certainly we're going to continue to monitor those as we see more variants. And hopefully, if we're able to stop the spread of the virus more, we'll be able to stop the spread of the variants. We're getting better, but certainly with each new variant, we worry about how that could resurge. And we have just of recent, within the past 2 weeks, seen a significant uptick in cases secondary to the Delta variant. And so when we talk about SARS-CoV-2, this is really still being studied. We've learned a great deal about it, but as I was just discussing, it's likely to continue to mutate. We thought that the viruses are still are looking into this about where was it obtained, bat pangolins. There were early cases linked to a market in Wuhan, China. And then we saw the spread of this virus through, mostly international travel through China and Europe. But as I said before, we've known that the coronavirus family has been around for a long period of time. It's actually named for those crown-like spikes that you can see here in this image of the virus itself. And so we think that it's mostly animal to human transmission events that then kind of lead to these emerging diseases. So for the purposes of this talk, I'll probably use SARS-CoV-2 and COVID-19 interchangeably, but if we're being technical in public health vernacular, the virus is the severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. Some of the other names that people have used: human coronavirus, novel coronavirus, the Wuhan virus. But really the disease it causes is COVID-19. So I'll use them interchangeably, but really it's when we're talking about the virus and the disease. And so what are symptoms? So maybe some of you have had SARS-CoV-2 or cared for someone who had COVID-19. Really the symptoms are very, very broad. So fever, cough, sore throat, loss of taste, loss of smell, shortness of breath, congestion, fatigue, muscle aches, headache, vomiting, and diarrhea. I would say in children, the symptoms that I would have tended to see were either respiratory or actually very GI related. So diarrheal, vomiting, headache actually was a very common sign also seen in children. You can see here the list of complications. We continue to learn more, and certainly I don't go into it in these talks, but we're learning more about long COVID, or really what are the long-term impacts of COVID-19. We have seen impacts on the neurologic system. We've seen impacts on the cardiovascular system. And really, what it's going to take is more time. We will continue to learn, and we will continue to follow and monitor individuals who were infected with the virus, who developed COVID-19 from a variety of severity. But we really have to wait and see what are the long-term complications of being infected with SARS-CoV-2. I think the things that are unique to COVID-19 are really the loss of taste and loss of smell, seen very commonly. Also, interestingly, with this virus, we saw more blood clots in different areas. And then in children, something that I think is really important, particularly for those of us who work with children, is the multi-system inflammatory syndrome in children. There also can have this in adults. So this is the Kawasaki-like disease. It is a diagnosis of exclusion. This usually presents 2 to 4 weeks after infection with SARS-CoV-2. It's really high fever, conjunctivitis, so redness of the eyes, red lips, multi-organ involvement. Kids can get really sick. We have had cases here in West Virginia. Fortunately, all of those have recovered, but certainly a severe manifestation of COVID-19, and something to always counsel individuals on, and also ask about if, they start to develop these symptoms later after being infected. And so it's not flu season yet, but many people have compared the flu to COVID. There's many people have said, it's just the flu. It's not just the flu. It's different. It's a different viral family to completely begin with. As you can see here, the incubation period, so the time, to get sick, you see with influenza, it's 1 to 4 days. SARS-CoV-2, we still have continued to look at this to see what is really the incubation period. And really, it's thought to be 2 to 14 days. And so the other thing that we talk a lot about with COVID-19 is how are you contagious before you even start showing symptoms, so that asymptomatic spread. And so as you can see here with SARS-CoV-2, it's thought, 2 to 3 days before you start really having symptoms, really you could be contagious, as well as after the onset. And then, as we continue to learn more about asymptomatic cases and learning about that, and transmissibility. So SARS-CoV-2 is more transmissible than influenza. It's not as transmissible as other infectious diseases that fortunately are vaccine preventable, like measles. So measles has a transmissibility rate closer to 9 to 10. So measles is a much more infectious, contagious virus, but SARS-CoV-2 does seem to be more transmissible than influenza. And then the case fatality rate is still following that. Since we've had vaccination, since December of 2020, we have seen a significant decline in deaths and mortality. And there was just recent reports that last month, 99% of the individuals who died from COVID-19 in the past year or in the past month were those who had not been vaccinated. And so certainly hope is on the horizon. We've started to see more opening up, more entering back more into those regular life activities. But with the onset of the variants, as we continue to monitor, certainly, and with pockets of places across the country, including here in our own state with lower vaccination rate, there certainly is still areas at higher risk to see spread. And then as we get into the fall, when we have influenza, which right now, last year we had a pretty flu season. Many people thought it was because we had to wear masks. People were still washing their hands. People really weren't still going out and gathering. We did see a good vaccination season for influenza. This year, there is concern that this is going to be a much more severe flu season. So we'll all wait and see. But hopefully we can encourage individuals to keep washing their hands and to also get their flu shot. So these are just some extra populations that really need to be, have some extra precautions when you have COVID-19 to consider. So we have seen impact in racial and ethnic minority groups, also in rural communities, people who experience homelessness, those who are pregnant or breastfeeding, people with disabilities, those with compromised immune systems. So whether they're on immune system or immune suppressing drugs, or they have an underlying condition that suppresses their immune system, or the very young, and then those with developmental and behavioral disorders. And so this was back early in the pandemic, but just basically this was the number of individuals thought in the United States who were at higher risk for severe illness if they were infected with coronavirus. SARS-CoV-2, we really did see have a higher impact of severe disease in the older population, so those older in life. As we've seen the emergence of these variants, we are starting to see younger people have more severe disease. So with original strain of SARS-CoV-2, it was really more those above 65 and older that would have more severe disease, particularly those in the higher decades of life. With the new variant, we're seeing that more people in their mid-40s to even 50s have more severe disease. And so we certainly continue to monitor all of this. And so here are just some different, I won't spend time on this, but just some examples. Perhaps you care for children or you have colleagues or you yourself, there are certain conditions that do put you at a little bit of higher risk for severe disease. So individuals, as Carol said at the beginning, I used to work with the cystic fibrosis population. Certainly any respiratory illness could have a higher impact on individuals who have lung disease. So I wanted to kind of go back, and many of us probably already know this, but I think we don't talk about this as much anymore because we talked about it so much in the beginning of the pandemic. But how does COVID-19 spread, and then how can we help mitigate? Obviously, we're going to talk a lot about vaccine because vaccine is our most effective prevention measure that we have to prevent the spread of COVID-19 now. But really learning about how we can how does it spread, and then how can we help mitigate that, especially as we start to move back into school. So what we know is that really this virus is spread mainly from person to person, those who are in close contact within about 6 feet, mostly through respiratory droplets. When someone coughs or sneezes or talks, they can land in the mouth of those individuals and then inhaled into the lungs. That's why we've been wearing masks. I'm in a hospital setting right now. We still have a mask mandate. I have to say, as a pediatrician, I've loved wearing a mask. I haven't had a respiratory infection since February 2020. I used to get at least 3 colds a year. The school nurses out there are probably shaking their heads. When viruses are going through your schools, or those of you who have children, the kitty crud that we always call it. But since wearing a mask, increasing washing hands, I personally haven't experienced those viruses that we've seen. But with this particular virus, that's why wearing the mask does tend to help with that. And again, as we talked before, some individuals have symptoms, but there's also some individuals who have no symptoms at all. And from a contagious viral standpoint, that's what's really worrisome, because you may not even know you're infected and potentially could infect others. And so we still continue to look, and there's more and more research that comes out all the time, but we definitely know that this is person-to-person spread, where respiratory droplets are produced. There's possibly this touching of contact of contaminated surfaces. Over time, that's been more and more thought to be less likely. And then, early on in the pandemic, individuals thought there could be potential like food transmission. That has really been disproven. As long as you're preparing food in the standard ways, there's not. It's more so probably, someone didn't wash their hands after they sneezed or something like that, but not, transmitted through foodborne transmission. And so this was a very frequent sign that we saw. How can we help prevent the spread? So avoiding those close contact with people who are sick, covering your cough, avoiding touching your eyes or your nose or your mouth when you were, out and about, wearing a mask, cleaning surfaces and staying home when you're sick, and then really, really washing your hands, which we're going to talk more about, because really for just infection prevention, for any viral illness, hand washing is one of the best prevention tools that we have, on top of vaccination. Obviously, for a lot of the children we care for, vaccines are only currently eligible for 12 and above, but we're going to talk about that here just in a bit. So these were just some of the key ways that we could minimize our chance of exposure. So really avoiding those gatherings. That's why you heard all of us, stay at home. Many of these have been uplifted. I think people have really returned back to regular life as we've started to see increased vaccine rates. And really, a lot of these prevention actions we still need to be taking, because there's still variants that are around. We do have a lower vaccination rate than we would like to see. Certainly, we want to continue to improve vaccination rates, but particularly in areas with lower vaccination rates, that does increase risk of spread. But really washing your hands, and then doing things that we probably should have been doing all along, but perhaps we weren't doing as well before the pandemic. But covering our coughs and sneezes, I still wear my face covering when I'm out in public, even though I'm fully vaccinated and have been since January. I think it's, certainly personal preference. If I know I'm in a gathering with individuals who've been vaccinated, I do feel comfortable taking my mask off. And that's certainly what the CDC's guidance is. But, certainly see more and more people not wearing their face coverings, and in our hospital, it's still our policy to wear a face covering. And then really being mindful of those high-risk populations is still going to be important. So as we talk about individuals who are immunocompromised or the elderly, or also we really need to start thinking about those people who have not yet been able to be vaccinated. So those who are 12 years and younger, although SARS-CoV-2 hasn't caused as much severe disease in that population, there's still a risk. And we have seen tens of thousands of children be hospitalized from SARS-CoV-2, and unfortunately, there have been hundreds of children who have died. And in fact, in 2020, COVID-19 was one of the top 10 causes of death in youth. So low risk does not mean no risk. And so I think that's the ongoing discussion as we have moving forward until we can get more children access to vaccination. What type of measures should we be taking? We'll talk a little bit about the CDC guidance. But I would be remiss if I didn't just remind everyone about the importance of hand hygiene. So you all probably know this, but really hand washing, it is one of the most effective ways to prevent the spread of germs. So washing those hands for at least 20 seconds, especially after you've been in a public place or blowing your nose. If you don't have, water and soap available, using a hand sanitizer that contains at least 60% of alcohol, making sure that you cover all those surfaces is really important. There was a study back, one of the earlier slides, we talked about MERS. So there was a study done in China, and during the MERS outbreak, they instituted hand washing in a school setting. So they would do timed hand washing. They had the least amount of absenteeism during that institution of that than they had in the prior, I think it was 5 years. So not only did they not see MERS transmission, they didn't see the typical GI bugs that got transmitted or the other viruses that we talked about in the beginning because there was that instituted hand washing. So we really still, particularly in those children who have not yet had the chance to be vaccinated, it's going to be really important that we continue to emphasize the importance of hand washing with either soap and water or a sanitizer, as seen here. So now I do want to transition as we spend the next few moments talking about COVID-19 vaccines. So vaccination is the best prevention that we have towards preventing the severe disease and death. And as we learn more, we're seeing that with vaccines, it also helps reduce the transmission of the virus as well, although we continue to look into that. And so right now we have 3 vaccines authorized for use in the United States. So mRNA vaccines, this is the Pfizer and Moderna products. So they provide a small piece of material with instructions to make the protein for the virus. So then if we come into contact with the virus, we're able to fight that off. The viral vector vaccine, which is the Johnson & Johnson or Janssen product, it contains a modified version of a different virus, and inside that is a piece of material from the COVID-19 virus that tells our cells how to make the protein for the virus so that we can produce antibodies. So these vaccines went through a rigorous standard clinical trial. There was actually more individuals enrolled in these clinical trials than we even would see in other vaccine trials, and now we've seen millions of individuals in the United States and around the world be vaccinated, and these vaccines have continued to show that they're safe and effective. So here's the current authorized for use. So Pfizer is the one that's authorized for years 12 and up. Moderna is currently authorized for 18 and up. Moderna, about 4 to 5 weeks ago, did submit to the FDA data to allow vaccination to 12 to 17-year-olds. Their data showed the vaccine to be safe and effective in that age group. The FDA has yet to authorize the use in that age, but that is something that we all continue to look to see and anticipate that happening. And then Johnson & Johnson, although they are doing studies in younger population, it currently right now is authorized for 18 and up. Currently, the mRNA vaccines are 2 doses. The Johnson & Johnson is 1 dose. I was just on a call yesterday with Peter Marks, who leads the FDA's his unit is in charge of looking at the data and working with the VRBAC and the advisory committee in regards to authorizing these vaccines. And, we continue to learn about the vaccines. There's been a lot of talk about, are there going to be a need for booster doses, or, really, like he said, is it just going to be to complete the series? It might be a 3-shot series. Right now, it's still 2 shots. That's what the FDA and CDC has said. Pfizer last week made some news by saying they think that there might be a 3rd dose or a booster dose needed. Right now, the CDC and FDA still are saying, it's 2 doses. The immune response has been robust from that. They are looking more at certain populations that are at higher risk who may not amount as much of an immune response, so like immunocompromised individuals, and will there be subsets of the population that might need a 3rd dose or a booster shot. So we continue to follow these vaccines' effectiveness and their safety. They really are some of the most monitored vaccines that we've ever seen in our history. So I'll just briefly go through this. Some of you may have been involved in giving vaccines, as we've had vaccination clinics in every county in West Virginia. And so with the Pfizer-BioNTech, this was the first vaccine that was authorized for use. Here are the common side effects: pain, swelling at the injection site, redness, which are pretty common vaccine side effects, tiredness, headache. Those were the symptoms that I personally experienced, but fever, muscle pains, chills, and nausea. There are many individuals who report more severe symptoms after the 2nd dose comparatively to the 1st. And then here's just some. I won't go into depth, but Pfizer is the one vaccine that needs to be reconstituted. So it comes with a diluent, which is normal saline. This vaccine made a lot of news because it needed to be stored at this ultra cold freezer temperature. Of recently, there has been, they're able to be stored in the refrigerator for a longer period of time. So actually 30 days before it's mixed. Once it's mixed, you have about a 6-hour window to use that vaccine. Excuse me. So when we talk about Moderna, the other mRNA vaccine, the side effects are really similar. Hold on one second. Sorry. The symptoms are really similar comparatively to what we saw with the Pfizer vaccine. Pain, redness, swelling at the injection site, fever. This is really a larger dose vial, so each vial contains 10 to 11 doses, and of recent time they tried to get 15 dose vials. In West Virginia, we really have continued to receive the 10 dose vials. This does not have to be stored at as cold of a temperature, so it's a little bit easier to be stored in certain sites. And they continue to look at the storage and handling of all these vaccines to see if they're able to be stored at different temperatures of the more typical refrigerated temperatures for a longer period of time. So Johnson & Johnson, again, the symptoms are pretty similar to really with all 3. Currently, Johnson & Johnson, as we talked about, is only a 1-dose series. This only needs to be refrigerated. I think the challenge with this vaccine is that, excuse me, the punctured valves really only last for up to 6 hours. And so there was initial thought, because this vaccine was able to be refrigerated, this will be a lot easier to take to mobile clinics or to, homebound individuals. But really, it still is a logistical challenge, because once you puncture that vial, you have to use it within 6 hours. So I'm just going to briefly talk about the indications and contraindications. I think this is a question that we frequently get. Really, the indications are right now for Pfizer, 12 and above. Moderna, we're anticipating it will soon be 12 and above, but currently it still is 18. And then Johnson & Johnson, I think we'll see it be 18 and above for some time as they're doing those trials. But they're not doing them as robustly as Pfizer and Moderna has been able to do. Both Pfizer and Moderna are doing trials down to age 6 months of age. Pfizer actually this week is planning to finish up their data from ages 5 to 12. And so we all continue to watch to see when they potentially may have that data to go to the FDA to ask for authorization for use in even younger populations. And so really what I'm asked, like, who should not be vaccinated? Really the contraindication to this vaccine is if you've had a severe allergic reaction after a previous dose to any component of the vaccine, or an immediate allergic reaction of any severity after a previous dose, or allergy to a known component of the vaccine. There's not really much in the mRNA vaccines. It's mostly lipids, nanoparticles, some sugars, protein, but there can be individuals who have an allergic component. So known severe allergic reaction to a component of the vaccine, it's recommended to not be vaccinated. As we've learned more, it's certainly recommended for those individuals to discuss with an allergist immunologist and see if there's another vaccine. So you may have an allergy to an mRNA component, but could you be eligible to get a viral vector vaccine or vice versa? A precaution to vaccination, so not a contraindication, but maybe someone who needs to be monitored for a longer period of time, would be those who have an immediate allergic reaction to another vaccine or injectable therapy. And really this needs to have a risk assessment, and then once you vaccinate that individual, monitoring them longer. So I had a patient that I vaccinated that had this. We just monitored the patient for a longer period of time. That patient did fine. And then I think it's really important to remember there's a lot of information out there, a lot of misinformation as well. But some of the things, people have said, oh, I have a food allergy, I can't get vaccinated. That's not true. A family history of allergy to oral medications, really, that's not a contraindication or even a precaution. And so it is recommended any person who has a history of anaphylaxis to be monitored a little bit longer, but otherwise every individual should be monitored. So here's what I briefly mentioned. If somebody is allergic to an mRNA vaccine, they could get the Janssen or Johnson & Johnson product and vice versa. And then here is just a list of the, if individuals know that they have an anaphylactic reaction to this, and this is available on the CDC website, clinical considerations. So I think it's also important, as we continue to vaccinate other age groups, what are allergic reactions versus a vasovagal reaction, so someone fainting, and then vaccine side effects. So people who experience post-vaccination symptoms, you want to really understand, what is it? Is it really an allergy, or did they faint? So we saw this a lot as the weather got warmer, that individuals were hot, and they would potentially pass out after being vaccinated. That's not necessarily a allergic reaction to the vaccine. It's more so a vasovagal event that happens. And so it's important because we want to make sure that we're assessing if that individual can receive a future vaccine, particularly in the 2-dose series. So it's always important to use that clinical judgment when you're assessing patients to determine what really is going on. And then really most allergic reactions are going to happen 15 to 30 minutes after vaccination. With vasovagal, you're going to see that more acute onset. And then kind of those local or systemic side effects, typically if we're going to see that, so the redness, pain at the injection site, fevers, chills, nausea, really will happen 1 to 3 days after vaccination, most occurring the day after vaccination. I certainly had pain at my injection site. I think it usually happened, I would say, about 12 to 18 hours after the injection. For about 24 hours, I would say. Between the HPV vaccine soreness and tetanus soreness is what my personal experience was. And then after 24 hours, it had completely resolved. Whereas usually when I get a tetanus shot, that my arm is sore for multiple days. So I talked briefly about safety and efficacy. This is certainly the question we get the most as a pediatrician. I get asked this a lot by parents, like, are these vaccines safe and effective? And safety has really been a top priority from the beginning. So they've been held to the same safety standards of all vaccines. So they've gone through the Vaccines and Related Biologic Products Advisory Committee. The Advisory Committee on Immunization Practices considers the safety. Those are independent committees that have experts from around the country. They take comment from the public and really make their assessment based upon the science. And then we've had monitoring of these vaccine safety and side effects once they're in use. And really, that has been incredibly rigorous, which we'll talk a little bit about. So what do we know about safety? We know now that millions of people have been vaccinated. There were thousands in the clinical trials. Now we've seen millions. And really, side effects are very rare. Of recent times, there's been a look into after the mRNA vaccines, notably Pfizer, is there an increased risk of myocarditis or pericarditis, so inflammation of the heart. And upon the review, that side effect or that event is very rare compared to how many cases there were when you look at how many individuals have been vaccinated. Those individuals have recovered, and also, the risks of getting COVID-19 certainly need to be considered. So the recommendation is that the benefits of vaccines outweigh the risk, even of the small risk of getting myocarditis or pericarditis. And so it is still recommended to vaccinate. And so we continue to look and monitor to see what type of events occur after the vaccine. So that is through the Vaccine Adverse Events Reporting System, which many of us are probably familiar with if you've administered vaccines. So this is where you report if there's been an error or if there has been a side effect. And then also VSafe is a new smartphone-based or web-based app that was launched solely for the COVID-19 vaccines. That is a surveillance program that conducts health checks. I just got a VSafe this week. And like I said, I got my first dose in December, my second dose in early January, enrolled in VSafe, and I still get periodic checks. I'd say in the beginning it was really frequent, and now it's about every month or even every other month. So we're continuing to monitor individuals and how they respond after the vaccine. This is certainly voluntary, it's not mandatory, but if you've been vaccinated, you can certainly enroll in the VSafe program. And so here's just another few examples of all the different monitoring systems that are in place. So when people ask you, what do they do to keep making sure that these vaccines are safe, there's a very robust monitoring system. And how effective are the vaccines? So they were highly effective at preventing COVID-19 in clinical trials, and all the vaccines that are authorized have high efficacy in protecting severe disease. So, you won't end up in the hospital or you won't die. And we continue to look at how effective the vaccines are to variants, and they continue to look as different variants change. With the Delta variant, which is now the most prevalent that we're seeing, there does seem to be efficacy towards that vaccine, the mRNAs, more so than the Johnson & Johnson product, but they are still efficacious. So it's important to note that people can still get COVID if they've been vaccinated. If you get COVID, you're less likely to end up in the hospital or less likely to die. And as I mentioned earlier, last month, the statistic, 99% of individuals who died to COVID were unvaccinated. And so they continue to undergo this rigorous scientific review by experts. So they continue to look at the safety and efficacy from those individuals who were in the clinical trials to see how long immunity lasts. One of the questions I commonly get is, well, how long is the vaccine going to last? My answer is we're still learning. Those individuals who participated in clinical trials that started in early 2020, we have almost a year of data, and we continue. They have antibodies, but we're going to have to continue to see how long that antibody response lasts and how long it stays robust. So I'm just going to talk a little bit about West Virginia as we finish up here in our last 10 minutes, and then certainly take any questions that you may have. So in West Virginia, I mentioned that I'm part of the Joint Interagency Task Force for COVID-19 vaccine. This is how our state took the approach to distribute and help coordinate administration of vaccines. So this was established by the governor. Both the Department of Education and the Higher Education Policy Commission serve on the Joint Interagency Task Force. Our task force remains active to this day. It's still led by retired Major General Jim Horroy, and really it's a collaborative effort of many different agencies and organizations to help ensure appropriate vaccine distribution and education when it comes to administration. We met together in December when the task force was upheld. We had been planning vaccine rollout since about August of 2020, and then we kind of went on site together to implement the plan and resolve issues, and we really were acclaimed or praised across the country for our vaccine rollout and our model of partnerships, and we were able to really lead the nation in the beginning of the vaccine rollout with our high efficiency of getting individuals vaccinated. And so we really took the country road less traveled. What we made really considerable news for is that we were one of the few states to not enroll in the federal pharmacy partnership. So we did our own state network of pharmacy partnerships with our long-term care facilities. That's allowed better flexibility with those relationships that were already established. As a result, we completed all of our long-term care facility vaccinations within 15 days. We then used that model to incorporate school nurses, school-based health centers, local health departments to vaccinate nearly 25,000 K through 12 teachers at the time, over 50. Then that was expanded to all eligible ages, including down to those 12 and above. And because of our aggressive and really swift implementation in our rollout, we experienced an 85% reduction in deaths in the first 6 weeks of 2021. And so certainly, I still remember to this day when the vaccines were authorized and when we heard of the first person in West Virginia getting vaccinated. It really was an all hands on deck effort, and certainly provided a great deal of hope and pride for the work that was done in West Virginia. We're still working and trying to get better to boost our vaccine rates and improve vaccine confidence, but certainly leading the initial stages of this rollout, vaccinating our most vulnerable population in a very efficient manner, did save many, many lives. So we continue to work in our structure. We had this whole of community approach where we would have large community vaccination clinics in all counties. It was led by local organization teams. Many of you may have been part of that. Pharmacy, local health department, community health centers. We've now seen more and more private practices or independent practices have vaccines. Hospitals were involved. So really using all the resources that we had to make this work. So we continue to do outreach, partnering with our faith-based community as they continue to be a very trusted source of information, which is what we're going to talk about next hour. We've been going to work sites. So we were the first place in the world to offer vaccination at a Toyota plant. So we went on site to deliver and administer vaccines, including families. As you've seen, K through 12 and 12 plus students, also working with colleges and universities, offering vaccine clinics on sites, and then really working with those local partners to have vaccines administered by local healthcare providers. And we continue to have outreach to the homebound patients, and we've seen more and more mobile clinics to reach into the more rural parts of our communities. So vaccine access continues to be an issue that we look for. Vaccines are really widespread now. We don't see, like we did in the beginning, where we had a very limited allocation of vaccine supply that required, allocation to the higher risk groups. Really now, vaccine is eligible for 12 and above. We have plenty of vaccine in West Virginia. They're available at many different locations, hospitals, long-term care facilities, local health department. We've had EMS give vaccines, pharmacies, really continuing in some areas these whole of community clinics approaches, although not as robust as they were earlier in the rollout, as we've not seen as much of a need. We've started to see more at fairs and festivals. We now do engage in the federal pharmacy partnership, although we didn't do it in the very part with the long-term care. We didn't feel it was the right fit for us. but we do engage where we have all pharmacies in West Virginia have access to vaccine. Many of them have more than one vaccine. And we recommend individuals, and this is where I would encourage you, if people ask you to go to vaccines.gov, here you can see the screenshot. It'll help you find a vaccine location near you. The state of West Virginia also has a COVID-19 vaccine info line, 1-833-734-0965. They can also assist in helping you get access to a vaccine. So here are just a few resources that I will share. We have vaccinate.w.gov that contains many different resources that we'll talk more about in the next hour. We have a social press kit that has different social media messages that you can share. It has graphics like the one you see there. I already mentioned the info line, and then the CDC and HHS and many different national partners have many different resources available on how you can talk to patients. So as we look into the future, we really want to continue to build vaccine confidence and really continue to expand access to reach into those harder to reach areas. We do anticipate younger age groups in the coming months. Some of my colleagues in the pediatric circles, we think potentially by September, you could see either 9-year-olds or even down to 5-year-olds potentially be authorized for use. And then I didn't talk a lot about this, but Pfizer has submitted the full FDA approval. Right now, these vaccines are authorized for use, but we do anticipate the vaccine to gain full FDA approval either by the end of the year or early into 2022. And then back to school, which all of y'all probably have certainly on your radar. As I mentioned, last week, the CDC came out. These are kind of the key takeaways from that CDC guidance of, how do we get back to school safely? And certainly the CDC recommended, the AAP has agreed with this, the American Academy of Pediatrics, that students benefit from in-person learning and safely returning to in-person instruction in the fall of 2021 is a priority. And so again, the emphasis on vaccination being the leading public health prevention strategy to end the pandemic. And by promoting vaccination, schools can help safely return to in-person learning. So not only the students, but also teacher and other school personnel, which in West Virginia, we did have a really robust percentage, and across the country, we have seen really good vaccination rates in school settings. Obviously, we want to always work to improve that and build more vaccine confidence. But certainly by promoting more vaccine, we'll see less disruptions in school activities as well as extracurricular activities. So the CDC guidance is that masks should continue to be worn in individuals by those 2 and older who are not fully vaccinated. Obviously, you want to have correct mask use, so not like a chin accessory, really covering the nose and the mouth is really that's recommended, particularly when you're indoor and crowded settings when you can't maintain that physical distance. The other recommendation is that there still should be that 3 feet of physical distance between students within classrooms, combined with indoor mask wearing for those who are not fully vaccinated to try to reduce that transmission risk. When you can't maintain that, it's really important to have other prevention strategies. So indoor masking, washing hands, like we talked about, screening tests, ventilation, hand washing, and respiratory etiquette, and then really encouraging individuals to stay at home when they're sick and to get tested, and then contact tracing, which I didn't go into a lot here, but those items still are going to be important that as we continue on, particularly as our younger age school children aren't yet eligible to be vaccinated. Again, important to emphasize the importance of students, teachers, and staff to stay home when they're sick or if they have any signs of an infectious illness, and to get tested to find out really, is this what do I have? Because again, as we talked about how the virus spreads, we want to make sure that we're reducing the spread as much as possible. And so it does talk about in the CDC guidance about schools who serve those under age 12 are not yet eligible for vaccine. So it's really important to have multiple layers of prevention. So the hand washing, physical distancing, masking, including all individuals. And we still need to remember that these prevention strategies are critical to protect individuals, including those who are not fully vaccinated or those who are not yet eligible to be vaccinated. especially in areas as we continue to look to see where there is increased spread of COVID-19. And so that's going to be ongoing importance that we continue to monitor how is the virus spreading in our communities as we also monitor other viruses that we talked about in the onset, notably flu, as it comes into the fall season. So those are some of the CDC guidance. I think the state is working on its plan now, but that's what I have for our first COVID talk, and I will see, I know I think we went right up to the whole time, Carol, but I can answer any questions if anyone submitted.
I don't see any questions, but now would be your time. If you have a question, just put it there in the chat. You're getting lots of thanks, Lisa.
Well, thanks for having me. And if you weren't too bored, is going to be really diving into what have we found in West Virginia, like why do people choose not to be vaccinated, or what do they more so choose to be vaccinated? And we'll talk about some strategies that individuals can use to try to improve vaccine attentions. But again, thank you so much for having me, and I look forward to anyone that can join the next hour as well.
Okay, we'll see everyone back, and thank you again, Lisa. Great presentation. Oh, here's a question. What is your opinion on quarantine timeframes? Is 14 days still the safest?
Yeah, so that's a great question. So there has been changes to the quarantine guidance over time. There is a test-based strategy. So if you're able to be tested, usually if people are going to start having symptoms, they would see symptoms within 5 to 7 days. So there is a test-based strategy that you quarantine, and then if you're able to be tested, and that test result can come back, PCR is still the gold standard of the testing, then you can end your quarantine. But by default, the 14-day quarantine is the safest if you don't have access to testing. But there is the recommendation that you can do a test-based strategy now that we have more available testing. And if your test is negative, then you can, that would kind of end your quarantine.
Okay, any other questions? All right, everyone, we'll see you back at 10 or 11:20, and we'll be on 5 minutes prior to the session starting. So, Lisa, we'll see you back as well. Thank you.
All right, we'll see you soon. Thank you.